afternoon, everybody. It would have been nicer to have a little better audience than this, but that's okay. That is the case. Yeah, that is the case when it comes to the things in the developing world. So that is the reality, bitter truth. We need to accept that. Right. I think most of the things that I was planning to talk about, I think you just touched upon them. And also, if I knew that three rather, right? 2 or 3 speakers are missing, I would have extended my talk by adding some more slides. But that's okay, we'll try to manage. So what I'm trying to tell you is what kind of help that the developing world can get in order to improve the pathology services by using digital pathology and AI. And also, after that, at the end, I would throw some ideas that I have in order to address the commonest cancer in South Asia and also in some African countries, the oral cancer, how the artificial intelligence and digital pathology can help to improve the diagnosis and also prognosis of that deadly disease. So this is Sri Lanka. Somebody, when I was talking outside, said, "Oh, Sri Lanka is part of India, right?" I said, "Not really. There's the 22-mile difference in the sea." So Sri Lanka is a small island, but level of literacy is very much similar to Japan, about 96%, and the health and education is 100% free. This is the most beautiful and the largest university in Sri Lanka, University of Pathology, where I come from. And the first Vice-Chancellor was Ivor Jennings. After Pathology, my university, he became the Vice-Chancellor of Cambridge. Yeah. Right. These are some of the realities in pathology practice wherever we practice. More than 70% of all the decisions in healthcare, especially delivering treatment, are taken after some sort of pathology report. That tells us how important pathology is. We all know in the developed world, for a fact, everything is up to the mark. But in developing world, we manage most of the patients with very basic pathology support. So that is the bitter truth that we need to understand. So therefore, when we say 70% or more of the healthcare decisions are taken after pathology report, I don't need to stress the fact that how important the pathology services are in order to deliver better healthcare. And this is what Lawrence was telling, this is what I am going to tell as well. Most of the pathology services in the developing world are very much lagging behind compared to the developed world. Now forget about the advanced facilities, genomics, proteomics, metabolomics, or whatever you talk about, but even the basic H&E facilities are not available to most countries. Immunohistochemistry, immunofluorescence, process sections, those things are not heard in some of these countries. So that is the reality. Because I travel in all those countries, I know for a fact that is the reality. So therefore, I think we need to look for the ways in which that we can help at least in a little way to this developing world. So having said that, the major problems are, I think Lawrence touched upon these things, lack of enough trained manpower in pathology. You take any subspecialty of pathology, some of the subspecialties are not existing in the developing world. But even basic histopathologists are not available for some of the developing countries. So that is a big problem. So we need to look at these things in the context of this conference, the digital pathology and AI, whether we have answers for this. I told you, forget about the modern technology, even the basic technology is not available in most of these countries. Now if you are giving a pathology report, especially for malignancies, we need to give it quickly. My principle is, if you can't produce a report within 3 to 5 days for a malignancy, I think that service I consider is not very effective. So turnaround time, especially in the developing world, is much higher. So we need to reduce that. Whether we can do that by introducing digital pathology and AI to those countries. And although the world is progressing in terms of knowledge very fast, are we getting the same thing in the developing world? Whether they are CPD, continuing professional development, and continuing medical education, are they up to the mark? It is definitely not. I know for a fact in some countries, not only pathologists, a lot of medical and other health professionals practice with their undergraduate knowledge that they imparted from different countries. So that is, for the modern world, not acceptable. So therefore, we need to ask the question whether digital pathology and AI can provide reasonable answers for these questions. So that is what we need to ask. And that is what we need to get help, and we need to help for the developing poor countries to improve those facilities. Now I mentioned about all these. I am sure digital pathology, mostly and to some extent artificial intelligence, have answers for most of these things. Lack of enough trained manpower, we can help them with the minimal facilities for digital pathology, if we have at least for telepathology, so we can overcome to some extent the inadequate manpower. Shortage of modern technology is again, although there is no manpower, if we have the technical support using digital pathology, we can transfer the slides to where the trained manpower is available and we can get the answers from. And of course the turnaround time, again, digital pathology, telepathology will help us. If at least we have a technical officer who can prepare slides in the department, and if we have a low-cost equipment, like we were talking earlier, at least to get the basic images, we can transfer them with no time, and certainly we can improve the turnaround time. Especially the countries where malignancies are so common in these so-called developing countries, especially South Asia and also Sub-Saharan and other African countries. So we can certainly make a difference. And I don't need to tell you how much we can put in terms of helping other countries, the professionals, the pathologists in those countries, to improve their continuing professional development by using digital pathology. So that way, I think we can give a lot of answers, significantly reliable answers for most of the problems faced by the developing world. I think these facts, I think Lawrence told you already. Now this is the reality. The Africa and South Asia, especially to some extent, some countries in Southeast Asia, have serious lack of manpower. Look at the China. China is becoming, it is no more a developing country, it is almost a developed country, but still, the patient, the population to pathologist ratio is not acceptable. Myanmar it is 1 in 170,000. There are some countries, sub-Saharan countries, where there is no pathologist at all, no anatomic pathologist at all. I remember when I was a trainee about 25 years back, we used to give a charity service from Guy's and St. Thomas's to Malawi, giving them the diagnosis only, no report, only the diagnosis. I still remember my teacher, Professor Sebastian Lucas, telling, just write the lymphoma. If possible, write malignant lymphoma. So that is all what you need. So that is the status of those countries. So we have to find answers for them. Now South Africa, the most parts are very developed, but still 100 pathologists for a population of 55 million, it is now even more. Zimbabwe, only 9 to 10 pathologists in the whole country. It's same in South Asia and Southeast Asia. If you look at countries like Cambodia, Laos, Vietnam, the number of pathologists are minimal, handful. But the disease burden is very high compared to most countries. So that's a big problem. So whether we can find answers by using digital pathology and artificial intelligence, yes, certainly we can, but only thing is making the infrastructure. Infrastructure can be afforded at a higher cost. So we need to look for low cost equipment, instruments to improve the digital pathology services in those countries. I told you at the beginning, there is shortage of modern technology. Now this is not modern technology, these are basic technology, basic facilities for a pathology department. Having frozen section, the immunohistochemistry and immunofluorescence. Now these facilities are considered as advanced, luxurious facilities in the developing world. There are not enough pathologists to interpret this, and also there is not enough technical manpower to prepare slides. Now if we can have at least the facilities of digital pathology, if we have at least one technical officer in a department to do immunohistochemistry, immunofluorescence, etc., so there is a way forward. We can transfer the images and we can get the diagnosis. And frozen section, especially, as I told you earlier, the malignancy is a big problem. Now, when they remove a malignancy, how nice for them to have at least frozen section facilities. Not many centers, believe me, either in Sri Lanka, India, Pakistan, in most places, they do excise cancers without frozen section facilities to assess excision margins. That is a bare minimum, very basic requirement. Immunohistochemistry and immunofluorescence, again, the same. Now in most of those developing countries, I know for a fact, there is one center doing immunohistochemistry and immunofluorescence for the whole country. So that is not acceptable. So whether we can find answers by using digital pathology is something that we need to think of. I am sure we can. I told you, forget about the facilities that I told you earlier. Now forget about the molecular genetics, etc. Translocations and various other things is a must now to diagnose most of the sarcomas. But those things are just dreams only for most pathologists in the developing world. Now even the HNE diagnosis is delayed due to serious lack of manpower. Although the HNE sections are prepared, there are not enough pathologists to report them. So if we can have the basic facilities to create images and transfer them, I think at least for malignancies, that is the way forward. Now, just let me deviate from that area and to come to the commonest cancer in South Asia. Now in Sri Lanka, you can see these GlobeCan data. Oral cancer is the #1 ranked cancer. Our neighbor, the India, again, it's not the oral cancer, the lung cancer is the #1 ranked cancer in males. Oral cancer is #2, but in Sri Lanka it is the #1. So therefore it is a big problem. So this is how we get them. Now all these patients came to our hospital and within a period of few months. I collected the latest pictures. Now reality is about 70% of the patients in South Asia with oral cancer present to clinicians with stage 3 and stage 4. What can you do? But the positive thing is, the most of these cancers, about 85% of these cancers arise in the background of a pre-cancer. We call them as potentially malignant disorders. Now these things should be diagnosed early. Risk of malignancy in these OPMDs are done with the presence of epithelial dysplasia. Now, there was one paper on oral epithelial dysplasia in the last session. Now, that is one area we have a lot of problems. Despite of the fact that we are having very many molecular techniques and various others, but still, oral epithelial dysplasia grading is done using H&E sections. All over the world, that is the reality. But that system has a lot of problems. I'll come to that later, so that I think that we can get answers for proper dysplasia grading systems in these patients by using digital pathology and AI. Now these patients, now these are the two common precancers in Asia, either submucous fibrosis or leukoplakia. This is completely due to betel nut, and this of course various reasons. If you look at the oral cancer patients in our part of the world, 85% of them have one of the two. Recently we looked at a large cohort of patients of oral cancer, one of my students, 48% of them had background submucous fibrosis. So therefore we need to have a system of dysplasia grading, reliable grading in order to prevent, in order to identify them early, A, B, in order to prevent over or under diagnosis, under treatment. So those things are very common at the moment because we do not have proper dysplasia grading system. So this is what they get at the end. Now mind you, for a developing country, now this is a specimen I received, for a developing country, for this kind of a surgery with microvascular reconstruction, in my hospital it takes 18 hours. Anyway, it would take 15 to 18 hours. Look at the economic cost, economic burden for a developing country when this kind of a surgery is done. These are done routinely. So therefore, this is a big burden. But we need to have a system where we can catch them early and give them a reliable grading of malignant transformation risk. I think for that, digital pathology and artificial intelligence can play a big role. Now, as I told you, this is how OPMDs or precancers, their risk is assessed by looking at architectural disturbances and the cytological atypia. Both those things happen due to accumulation of various genetic changes, and they are prone to get oral cancer. Now this is the latest definition that we gave in the last WHO classification for epithelial dysplasia. Now this is the reality. Now if you look at, now that's the normal epithelium, now we do get oral cancers developing in the normal epithelium without any morphologic changes, only with molecular changes. And we get without dysplasia. We get oral cancer arising from mild epithelial dysplasia, moderate dysplasia, and also from severe dysplasia. Very many entry points. Therefore, this grading of dysplasia correctly is very important, because when you go down the ladder, the chances of getting malignant transformation also becomes higher. Now we were looking for answers whether we can give a better criteria, better system of grading epithelial dysplasia in order to catch these OPMDs early, but we could not. Now this is the latest 2017, the group that we did the classification, but still we have not given a classification which is reliable. I am 100% sure we can give better answers if we have proper digital pathology and artificial intelligence combined with our H&E sections. I have some ideas, but we will try to work with Nasir Rajput and others who are experts in artificial intelligence and digital pathology. But at least when we have the next WHO classification, I would like to see digital pathology and AI coming into dysplasia grading. The problems that we have are these. It's very subjective. Therefore, the inter and intra-examiner variability is enormous. Something I call mild dysplasia today, if I see the same slide tomorrow, I might change my mind and say, oh, could be moderate. If I have some fight with the wife or somebody, I might say, oh, no, it looks like severe. So that kind of subjectivity, and intra-examiner variability exist in dysplasia grading. And also it is very difficult to reproduce individual features. There are 8 cytological ATP and 8 architectural disturbances, very difficult to reproduce some of them. Why not we use digital pathology and artificial intelligence for that? The things that the naked eye cannot do properly. And also, dysplasia grading, the pathologists who are here in the audience will recognize, most of the time we do not have a very good qualitative versus quantitative difference in grading dysplasia, early dysplasias. And also the present grading system that we use does not have a good prediction of the clinical outcome. So all those problems are there. So therefore, I think digital pathology and artificial intelligence can play a role in reducing most of these shortcomings that we experience at the moment. Now these are the architectural disturbances, 8 of them, and cytological ATP again 8 of them. So we refined last year when we came up with the new WHO classification. Now we have the quantifiable number. Now AI and digital pathology can play a role in designing a new good system. Now but when we say, for example, increased nuclear cytoplasmic ratio, for example, how increased? That we do not take into account at the moment. Sometimes very high, sometimes it's very little difference. Why can't we calibrate those things using AI? Why can't we produce algorithms to identify how pleomorphic, how hyperchromatic? Just identifying it is hyperchromatic, it is pleomorphic, etc. So quantifiable values can be given to these things, and I'm sure algorithms can be produced in order to get proper diagnostic criteria. So this is what the latest classification. We have mild, moderate and severe, and we have introduced the low grade and high grade. Again, low grade and high grade, we usually go by this, 4 architectural disturbances and 4 cytological atypia. So, nicely quantifiable features. Therefore, I think digital pathology and AI can play a role in this. So this is what I ask. I'm sure answers are there. Can digital pathology together with AI provide a better grading system for epithelial dysplasia? I am sure it can. So that is up to our computer experts to join hands with us, the pathologists, and to come up with a better grading system. That will definitely help to diagnose these things early, and to diagnose correctly, and to correctly predict the outcome or the prognosis. Therefore, they will get a better deal. Just to show you, now if you look at, now these features, increased nuclear cytoplasmic ratio, I told you, look at the size of the nucleus, a little cytoplasm, it's varying. So these things should be able to quantify. Now when we say increased mitosis, there are abnormal mitosis. How many abnormal mitoses are there in the field? You give a score and have an algorithm and come to a proper grading system. I am sure we can do that by producing images after images and combining them with various algorithms. I am sure rather than just mild, moderate and severe, we can come to a very scientifically sound dysplasia grading system. That will help hundreds and thousands of patients in the developing world especially. We have been trying to produce various prediction models for oral cancer. I have done 3 times this, but none of them are very successful. This is a new one using depth of invasion, the pattern of invasion and the T or the tumor size, clinical size. It tells us these red areas are all high-risk areas where this we did to select the treatment option for clinically negative necks, whether to go for an elective neck dissection or not. All these red areas you can see the depth of invasion, various pattern of invasion. When they have pattern of invasion 3 or 4, depth is more than 4, and T size 4, they invariably, without having clinically positive neck, should go for clinically prophylactic neck dissection. So these things are there, but this is by statistical model. Can't we get the help of digital pathology combined with AI and statistics to come up with a better model? So this is a must. I think there is a long way forward if you join hands, the computer experts and the pathologists, to look for answers for this very big problem that the developing world is facing. I am sure by helping the developing world to develop at least the basic requirements of digital pathology and AI, I think the future of those innocent victims in the developing world will be better. Thank you very much. All these things you can read, but I touched upon those things.
Any questions? Yes. So, if you allow, I have a couple of questions. So, one is, when you say that, say we can use AI or machine learning tools to look at better grading systems. Now, do you mean that better grading systems possibly implies finding more imaging biomarkers, for example? So because that's one of the usual trends in AI. Like you are essentially looking at discovering better imaging biomarkers. So that is one question. The second question is that you mentioned that when patients actually visit the hospital, the cancers have already progressed. So now to enable early detection, we can't really rely on patients coming to the hospitals, right? So there could be say screening programs which are, for example, existing for the cervical cancer cases, right? At least in some places in India. So so similarly, for early detection, can there be screening programs which do not involve biopsies, but which may involve similar non-invasive methods like clinical observations or smears or breast biopsies and so on? And there also, I believe AI and machine learning can contribute. So that's
Yes, I agree with you. Now, what I said was exactly that. Whether we can identify the biomarkers to combine them. Now, although we say these 8 features, each architectural disturbances and cytological atypia, we don't know for a fact what features are more important in terms of predicting prognosis, predicting malignant transformation, predicting better outcome over the worse outcome. So those features, if we can identify with image analysis, those features we can combine into the future grading system. And the second question that you asked, there are screening programs without doing a biopsy. If you take oral cancer, our commonest thing, yes, we use toluidine blue, and also there are various gadgets called Wellscope and various things, using autofluorescence, chemiluminescence and various things. There are things, yes, that is good for the mass screening, but the answers are not great. But what I was referring to is, once the biopsy is done, at least at that stage we should have a proper scientifically proven report saying that now this particular case is going to transform, this particular case once you withdraw the habits will regress, that kind of a scenario. So that is not there with the current system. That is what I was referring to.
Very enlightening talk, Professor Tilakaratne. Thank you for that. I just wanted to ask, so we know we have a problem of less number of pathologists ever engaging more work and all the problems that you mentioned in low and middle income countries. And we know that there is a lot of potential for the computational pathologists for the computational scientists to provide some answers which are relevant. But we also need the appropriate instruments to be able to do that. How much of engagement from the industry side do you see in low and middle income countries, and what's your experience of that?
And this was discussed earlier also with him. Lawrence raised some questions. We can't find fault with the industry. Industry is always trying to make profit. So you can't find fault with them. But unfortunately, in terms of low-cost equipment to be used in digital pathology or for that matter in AI, it's not available in the developing world. I think that is what all these companies should think of. Now, when you go out there, all those gadgets, I note down the prices. I don't think any of those developing countries the governments can afford. Even the private sector is not very developed in most of those countries that we were talking about, except especially in Africa. In South Asia, I think private sector is very developed, although they are developing countries. But I don't see any low-cost equipment. I think it should be. Now, if you go to a supermarket here in the UK, now there are brands which can be, afforded by every group of the society. The basics and also other stuff. So that kind of thing should come to the developing world when it comes to the scientific equipment also. True, we have some of the things, but at least compromising the quality a little bit. Low-cost equipment should come to the developing world if you are to move forward. So that has, I think to my knowledge, has not happened. We can't find fault because this is a developing field in the developed world also. I'm sure all those companies, once they establish in the developed world, I think they will think of having some low-cost equipment to the developing world also. I wish it should happen. Yeah, that's right. Now, if you look at even the developing countries, now some centers, very few centers, they have some facilities. Now, if you look at now, although Sri Lanka, for example, now my center, I have most of the facilities that the developed world has. But at least within the countries, if we can develop the digital pathology, the basic facilities, without thinking the other countries helping out, I think at least the developed centers should start helping their poor places where they cannot, where they don't have even the basic facilities. Now, for example, within the country we give the telepathology services. So we have all the facilities, and the other pathology, those who do not have facilities, or expertise, they can send the images. For that, I don't think we need a lot of technical stuff. All what we need is the internet facilities and the basic facilities to take some images. That kind of things are happening. But beyond that, these are very difficult areas. As you said, there are departments struggling to cut a 5-micron section. So then developing digital pathology in a place like that is difficult, I understand that. But still, I'm sure the companies should play a little role in this. So that is what I feel. I strongly believe that they should be able to offer some help to the developing world in terms of technology.